Hello, everyone, for another virtual shadowing webinar with WebCeph X. And today we are joined by Dr. Trey Perez, a pediatric dentist from the United States. Thank you so much for joining us, Dr. Perez. And whenever you're ready, the floor is yours.
Okay, thank you. And thanks for having me. Good morning, everybody. My name is Dr. Perez, Trey Perez. I'm going to talk to you about pediatric dentistry. Let's get going. I'll tell you a little bit about myself. Let me fix. There we go. So I'm a pediatric dentist. I am board certified. I'm based in Brooklyn, New York. I'm also an associate director at Brooklyn Hospital, the GPR program. If you're not familiar, GPR is a general practice residency. So that's for people that want to become general dentists after dental school. So for New York State in particular, you have to do a residency, whether it's a GPR or a PEDS residency or other specialty. You have to get that before you get your license. In California, you can do that as an option, or you can take certain exams. In other states, there's different rules. So wherever you want to practice, make sure you know the laws for and the regulations for getting your license. So I work in a hospital. I also work in private practice. So as a director and a hospital dentist, I'm an attending, which is, if you're not familiar with that term, it's basically a teacher, in a hospital. You may see shows like Scrubs and things like that where you might have learned that. But so I pretty much supervise and, I'm an educator, clinical instructor there. So I've taught both general dentists and pediatric dentists. I wrote that twice. I'm assistant director twice, sorry. And I do a lot of outreaches too. So I'll talk to you about everything and we'll go over some cases. So my journey began at Syracuse University, where I got my biology degree. A lot of people do a BS in biology, but it's not necessarily mandatory. I've known people who studied art and music and things like that. So you just have to fulfill your requirements, and that depends on the school. Most of the schools are the same. So make sure when you're applying to school, you find the requirements for sciences and things like that. But you don't have to be a biology major. So after that, I wasn't sure exactly what I wanted to do, but I went to the University of Florida and I got my master's in public health. And there's different tracks you can go with public health: epidemiology, biostatistics, environmental health. What I did was policy and management. And then after that, I went to NYU, which is the biggest dental school. A lot of people have gone there. Probably you've heard of some people already that went to NYU. I did 4 years there. Then after that, I went to Brooklyn Hospital, where I did my GPR for 1 year. And then I went back to NYU to do my 2-year pediatric dentistry residency. So I'm proud of my journey. It is a lot of work. As I was talking with the guys before, dental school is very tough. It's probably the toughest years of your life, but it's very doable. And I'll probably mention this at the end. It's a lot to do with balance, your work balance, your school balance, your personal life, things like that. That not just in school, but in your career too. So if you have a good balance, I think it makes it a lot easier with your health and your mental health. So what is a pediatric dentist? It's one of the ADA recognized specialties. There's I think there's, as of a few years ago, there's over 8,000 of us, compared to over 160,000 general dentists. It is a 2-year residency program. Typically, there are some 3-year residency programs, but majority are just 2 years. And that's after dental school. You don't have to go right away into your residency right after dental school. You can do what I did, a GPR for 1 year, or you can go to private practice. Many people do. But as far as the specialty of what we do, it's age specific, whereas other specialties are more procedure specific. If you're going to endo, you could be doing root canals. If you're going to be doing perio, you're going to be doing a lot of surgeries, and then with ortho, you're going to be doing braces and things like that. But this is, where those are more procedure specific. We do more age specific, so it's a little different. Mostly it's 0 to 17. Most kids are supposed to see the dentist by the time they're 1 year old. So which really 1 to 17. But we also see special needs patients. That's part of the specialty, and not just children, adults as well. So if you're into that, that's something you can do as well as part of pediatric dentistry. There's also general dentists that do special needs dentistry. I'll talk a little bit more about what you can do with that as well. So it's not just fixing baby teeth, it's a specialty for a reason. We focus on development and not just dental development, although that's a huge thing. We talk about craniofacial, so the bones of the face, the physical, their overall health. Even though you're a dentist and you're focused on teeth, you still have to consider the health of the entire patient, because the teeth are connected to everything else. And we don't just focus on teeth, we talk about soft tissue, tongue, lips, gingiva, muscles of mastication, the muscles you chew with. So there's a lot. And of course, psychology. You have to deal with the psychology of a growing person. So a 1 or 2 or 3 year old, they're all going to be a little different. And then when their cognition improves and they develop a little bit more, 5, 6, 7, they're going to be a little different in how you approach them versus, a teenager. Okay. So there's, development issues, psychology, all of that, that plays a big factor. So behavior management, your bedside manner, that's a big thing, more chairside manner in dentistry. But so that's a really big thing. Behavior management isn't just, talking to the patient, but we have other modes of behavior management, pharmacological behavior management. So that includes nitrous oxide or laughing gas, sedation, and general anesthesia. So when you go into dental school or residency, you'll learn about those things. And dental anesthesia is just recognized a few years ago as one of the ADA specialties, but it's been around for a while, and it's getting more and more attention. People want to be sedated or put to sleep, whether it's them or their kids. They want to be sedated more and more, for their dental treatment. Dental anxiety is a huge thing. That's something that we have to deal with, especially as pediatric dentists, but everybody is nervous when they go to the dentist. So something to think about. Nobody likes dentists, right? So that's something you have to deal with. Everybody hates dentists, everyone hates lawyers, and that's something that you're gonna have to deal with. But they come to you when they need you to. So we are, a big part of society. We have to contribute, and it is a rewarding career no matter what. We do focus a lot on preventative dentistry. You probably heard the expression, prevention is the best medicine, and that goes for dentistry too. So a lot of fluoride. Sometimes we just do simple fillings. We do something called SDF, which is big now, which stands for silver diamine fluoride. I'll talk about that a little bit too. And in some ways, we are primary care because we see, so if you don't know what primary care, secondary care, tertiary care is, that is usually your primary care is the person you go to see first. So that means your pediatrician or your family doctor, internal medicine or whatever, or your general dentist. And in some cases, a lot of cases, a pediatric dentist. Secondary care is sort of a specialist. So if you go to the doctor and he's not sure what's wrong with you or she's not sure, then they'll refer you to, the next doctor, the specialist, to figure out, what's going on. Or if they can't treat it for whatever reason, they'll send you to secondary care. And so with secondary and tertiary, it's just more specific, more specialized treatment. So we do get a lot of patients that come directly to us as pediatric dentists, but we also get a lot of referrals. So general dentists or sometimes orthodontists, if people can't treat them, or they, for whatever reason, or they don't want to treat them, they don't treat kids, or orthodontists typically they'll need a tooth taken out for braces, or if they see decay and they need it to be treated, then they'll send it to us. So we do get referrals. I would say 95% is primary care. They come directly to us. So I'll talk about the pros and the cons. For me, this is like my opinion. If you talk to some other pediatric dentists, you might get some other opinions. But what I like is quick appointments. They're sort of in and out. You can't have long appointments with kids. They have short attention span. So when I'm teaching, I tell this to the patient or to the residents. Once you sit that kid in the chair, they have a timer, and this goes for everybody. And once they sit in that chair, that timer starts, and you don't know when that timer is going to end. But when it does, they're not going to behave anymore. They're going to be upset. For adults, that timer is a lot longer. We're more patient. We can sit through, maybe hours. But at some point, still, if you think about, how long are you going to be in a chair on the waiting room before you get a little cranky, upset, and then think about that for a child. The timer is going to be a lot shorter. Instead of expressing it in ways of I've been waiting here a long time, I'm upset, or whatever. Kids cry, they kick, they scream. So it's a little different. The procedures are short. Do a lot of crowns, extractions, and the crowns and peds is a lot. They're a lot quicker. They're sort of just take a few minutes, set it, and then get the kid out of there. So that's something that I like. So if you're into instant gratification, that's something more that might be up your alley. There's not too many things that we do. It's really a handful of procedures, and I'll talk about that in a sec. There's not too many emergencies. There's a lot of trauma. I wouldn't say a lot of trauma, but it happens every once in a while. I'll show you some trauma cases in a bit. It's mostly dental trauma. Usually if it's other emergencies like broken jaws or facial swellings and things like that, they go to the hospital or the oral surgeon or something. It's typically healthier patients versus adult patients where you have chronic diseases like high blood pressure, diabetes. Those are the most common. I do see a lot of kids that have asthma. That's super common. And autism, I feel like those are the two most common. And then with autism, if you don't know, it's a spectrum. So there could be kids who are not cooperative at all, who don't talk. And then there's kids who are, you have no idea. So, that's, a lot of what I see on a weekly basis. Depending on what you want to do, you can do sedations, you can do general anesthesia. I typically do general anesthesia twice a month. I don't administer the general anesthesia. An anesthesiologist does it in the hospital, which is great. It's very safe. A lot of people get concerned about that, but it is very safe, especially when you're in a hospital, especially with a anesthesiologist. And I work with pediatric anesthesiologists, so they're always in good hands. I've never had an issue. So if you're into Disney, Star Wars, Avengers, I'm a big, you can see Wolverine over here and Captain America. I'm a big Avenger Marvel fan. So if you're into all that stuff, Mickey Mouse, Star Wars, whatever, then into that kid stuff, then it's a lot of fun. The hours are good, pretty much 9 to 5. You could make your hours as you want. You typically get a higher pay as a specialist. I typically only work 4 days a week, which is nice. And your fillings don't have to be perfect. You don't have to do, this amazing cosmetic stuff. You sort of do what you need to do. You get it done, and you sort of stabilize the patient, and hopefully everything can last as long as possible. Because sometimes these kids are kicking and screaming. Ideally, you want someone to sit still and be totally perfect behavior and get everything done, but that's not always the case. And kids are fun. Kids say the funniest things sometimes, and it's a lot of fun. They can really brighten your day. On the flip side, kids are awful. Kids can be also the worst. They can kick, they can scream. I've been bit and punched and kicked. So sometimes there is a little wrestling involved, but that's usually rare, to be honest. Parents are typically that driving force. There are parents that are the more demanding, and since it's not them, it's their kid, they're very protective and things like that. And the behavior, parenting styles have changed over the years. So it's almost like kids have more autonomy and more independence, or over things. So it's a little different. But bad parents, bad children, bad behavior. It happens. It's part of the the job. And learning to deal with that is difficult. It's not something you get taught in school. It's something you've had to learn over time by doing. Well, some people are naturally good at it, but it's something I've had to learn for over time. You do get the argument, they're just baby teeth, they're just going to fall out. And that's sort of a frustrating thing because I'm a pediatric dentist. I spent 2 extra years doing a residency to become a specialist. And I didn't do that just because teeth are going to fall out. So that's a very frustrating thing you have to deal with, because, it does affect their entire health. Parents, do neglect their kids' teeth because they think this, and it can be very frustrating. With kids, there's higher rate of anxiety. I believe the statistics are, 70% of adults have some sort of dental anxiety. And there's maybe like 5 to 10% that have such a dental phobia that they won't even go to the dentist. So you can imagine that's even higher for children. Kids, they don't really know how to deal with anxiety. And sometimes parents even use going to the dentist as a punishment, or they'll make a joke about it, and it makes your job a whole lot worse. Like I said, I only work 4 days a week, and that's typically because there's higher burnout. Dealing with the emotional and psychological, and sometimes physical aspects of pediatric dentistry it can wear you out. So I know a lot of pediatric dentists that work 4 days a week. Some that even work less. But for me, since I have the balance of working in a hospital 1 day a week and then private practice the rest of the week, it sort of balances it out. I like that sort of variety, and that's something that you can do as a dentist, whether it's pediatric dentistry or any other specialty, really. One thing, it's not as glamorous, and there's less glory as other dental specialties. Typically, I don't do anything that's cosmetic, and that's I'm not doing smile makeovers and things like that. So you see a lot of people on Instagram or social media that are doing these, moving teeth, like, great ortho cases or great cosmetic cases, or reconstructive jaw surgeries and things like that. We're not really doing that. So there's less of that. But to go on, it's still a great, profession. So the path to becoming a pediatric dentist, I sort of mentioned it. It is one of the most competitive specialties now. It's up there with orthodontics and oral surgery. It is a 2-year residency program, sometimes 3, but mostly 2. You do training in the OR. That's with general anesthesia. A lot of my colleagues still do OR dentistry. Not too many do sedations. But then again, it's up to, what you want to do, what you want to do in your career. And that's a great thing about dentistry. You can do this procedure, do that. If you didn't learn it in dental school, you can do it with continuing ed down the line. And the difference between sedation and GA, if you're not aware, sedation is, GA, you're completely asleep. You have a tube going down your airway. You have an IV in your hand. So the patient's completely asleep. They're hooked up to a machine, they're hooked up to monitors, and they have no recollection of, what's going on. With sedation, they have no memory of it, but they can still move. They're still breathing on their own. And depending on what type of sedation, it can be oral, so they can take some usually like an oral, like a syrup, little medication, usually something like midazolam, which is similar to Valium or Xanax. And that sedates them. It causes temporary memory loss of, while the drug is in effect, but they still seem awake. They can respond to your commands. They're breathing on their own. Sometimes they do fall asleep. There's also IV sedation, intramuscular sedation, but with IV, it's a little bit more controlled. You can give a little bit more. They're still breathing on their own. But I won't talk about that too much. That's something you'll have to learn in dental school. There are different levels of sedation. But we do focus a lot on development. So it's not just, it's residencies like in between dental school and private practice. So you do see a lot of patients. Dental school, you might have a couple of patients a day, maybe like half the day it's patients, and then the other half is didactic stuff, especially in the last 2 years. Especially for me at NYU, that's kind of how it was. A lot of didactic stuff in the first 2 years of dental school, and then lab work, learning how to do preps on plastic teeth. But in residency, you're seeing patients pretty much all day, and you typically have a short lecture or presentation or something at some point during the day. So, and a lot of that focuses on development, development of the teeth, development of the jaws, facial development, psychological development. So there's a lot to talk about. But it's not just development, it's not just sedation, it's prevention, dealing with trauma, dealing with different dental procedures, pathology, pretty much everything you can think about. You have to do a research project in your residency, and this is typically presented at the annual Pediatric Dental Conference. That's usually in May, so that's part of the requirement. You don't have to be board certified. A lot of my colleagues are board certified or are trying to get board certified. Typically how that works is you take a written exam the spring of your second year of residency, and then the fall of the following year, so like almost a year and a half later, you do an oral exam. And that's how that works. Is you have 2 examiners, and for about 2 hours you answer a bunch of questions. They give you cases and you answer it. So it is something that I'm proud of that I finished. I would strongly recommend it if you do that. And you can do that in any specialty. General dentistry doesn't really have one, but you can do like American Academy of General Dentistry fellowship and masters and things like that. So typically, let's talk about a typical day in private practice. There's a lot of volume. Since I mentioned before, it's short procedures, quick appointments, so you get them in and out. Most of the time, it's exams. It's probably like 4 to 1. So like for every 4 recall patients, exam patients, cleanings, then I do, some type of treatment, whether it's, fillings or crowns, extractions, etc. If I don't have a hygienist, then I typically see like 20 to 40 patients a day, but I know of practices that they can see up to 100 patients a day, and they have multiple hygienists. So they're just coming for a quick exam and then go back to the room and do a procedure, then do a few more exams. And if it's a well-oiled machine, you can see tons of patients. Okay. And then the more patients you see, the usually get paid on production. Or if you have your own practice, then, you pay yourself on production. So the higher volume, the greater the income. So in hospital dentistry, what I do, it's still a higher volume, but since the residents are seeing the patients, we're learning, so we go a little slower, but for them, it's higher volume than the days they see only adults. Typically in the hospital, it's lower socioeconomic status, lower education, lot of the families live in public housing around here in Brooklyn. So with that, also we have a lot of immigrants. So with all those factors, they have a higher caries rate. So there's more decay. We definitely see more decay. The treatment needs are a lot greater. I definitely do more OR cases with these patients than with private practice patients. And that's the rule. There's always exceptions, of course, but typically there's different factors that are going to increase the risk and likelihood that a child has decay. It's a lot of academics. So, I'm teaching these residents, I'm supervising them, I'm guiding them how to do pediatric dentistry. The dentistry itself, the crowns, the extractions, the fillings, they're a lot easier, a lot quicker than what you would do for an adult, especially crowns. Crowns usually take a couple appointments when you're as a general dentist, but for pediatric dentists, it's one appointment. It's very quick. So we do multiple crowns in a few minutes in one appointment, which is great. And it's something that the dental students, dental residents are a little nervous of, but I try to guide them through it, and because then they realize it's an easy thing to do. There are more sick patients. That means they have more comorbidities than you might see in private practice, but still it's not as much as if they were adult patients. And I mentioned OR and general anesthesia, which I do every other week at the hospital. So I sort of numbered these as, most common to least common. I do exams all day long, and exams that include the preventative stuff like cleanings, fluorides, sealants I do occasionally. These are under the preventative guys there. So sealants are preventative, SDF, space maintenance, but mostly it's cleanings and fluoride. All right, and then fillings, and then stainless steel crowns, and extractions, pulpotomies. And pulpotomies are baby root canals, basically. They're a little different than adult root canals or pulpotomies or pulpectomies, but the end game is sort of the same. You just want to preserve the pulp as much as possible, and preserve the tooth for as long as possible until it's ready to come out. It's not like a root canal where you want to maintain that tooth indefinitely to the end of the person's life. You just have to maintain it until the tooth is ready to come out. So that's one good thing about pediatric dentistry. You have to figure out how long is this tooth going to stay in the mouth, and what's the best treatment for it. Is it a filling? Is it a crown? Is it an extraction? Is it a pulpotomy with a crown? So yeah, but I don't do too many pulpotomies. We're sort of getting away from that because pulpotomies tend to fail and then tooth needs to be extracted. And with stainless steel crowns, that's still the gold standard for pediatric dentistry as far as crowns. Those last a lot longer compared to fillings. We don't do porcelain, although there are some porcelain, zirconia crowns. The main thing for pediatric dentistry is stainless steel crowns. Okay. Behavior management, sometimes that's just talking to the patient, positive reinforcement, things like that. Sometimes we do have to strap them down or hold them down, especially if they're too young, or if there's some sort of emergency. Sometimes we have to hold them down and take a tooth out, and that's sad and difficult, but sometimes you have to do that to take care of an infection, or if the kid's in pain, things like that. Emergency sort of stuff, or urgent at least. Nitrous oxide, I do that pretty often. I don't do sedation, but that's always an option. And then general anesthesia occasionally. So the complaints that I hear a lot are there's a hole in the tooth, or there's a staining, there's black in the tooth. Most of it comes down to its dental caries, it's tooth decay. parents sometimes want to be in denial about it. So they'll say there's a hole in the tooth instead of he has a cavity or she has a cavity. I see that a lot. Pain occasionally. Sometimes there's swelling associated with that. Sometimes there's not. Usually it's just localized swelling, and it's not facial swelling. Facial swelling requires sort of a different approach. Sometimes we'll see trauma, and I'll show you some cases. It's usually a broken tooth. Sometimes it's a tooth comes out, call that an avulsed tooth. Luckily, that doesn't happen too much. And of course, developmental issues. So sometimes crowding, sometimes teeth are growing behind other teeth, sometimes they're growing in the wrong way. And patients or parents ask all the time, is my child going to need braces? And sometimes they ask that when the kid is like 3 or 4 years old. I'm like, this is way too early to tell, if they need braces. But sometimes there are like, you need to go see the orthodontist yesterday. Like it's that bad. You need to go see something. The jaws aren't developing the right way. You have to do some type of growth modification. So it's all of that pretty much every day. So speaking of development, this is a complaint I see a lot. This is actually totally normal. Parents usually call this the shark teeth because you have these permanent teeth growing behind the primary teeth here. And this is totally normal. I would say 99% of the time, these baby teeth will fall out on their own. It's pretty rare that I have to take them out. I don't like taking out baby teeth. I don't like extracting teeth unless I really need to, because this kid is probably between the ages of 5 and 7. Usually these teeth come out around 6. So I would say that's the average age. So give or take a few years. If I can, so a kid that in that age range, if you take out a tooth, or if you just mention we have to take out a tooth, they tend to get anxious, they tend to cry. And then when you do take it out, they can start kicking and screaming. So it does cause trauma, psychological trauma. And that's something you want to avoid. So it's really rare that I take these teeth out. I just tell the parent, this is normal. This is normal development. The permanent teeth are supposed to come in behind the baby teeth. And what happens is eventually these become loose and these will move forward because the tongue typically pushes them forward and it goes along the entire arch here. So that is totally normal. It's a common complaint. So hopefully I can educate people so they're not coming in for that. Okay, so here's SDF. This is silver diamine fluoride. It's actually been used a lot in the past in other countries outside the US. But it got approved by the FDA in 2014 to be used in dentistry. There was one company for a long time that got up the approval. I think there's some other companies have also recently been approved. So there was this one company. So, there's one company, it's a little bottle, which is, about this big, has about 250 drops of this SDF in it. It costs like $180 for a tiny little bottle, and the bottle's only worth about $8. So a good thing about SDF, it's actually the most cost-effective way to treat dental decay, because a little $8 bottle with 250 drops, and one drop would do all of these teeth right here. Usually it's like only 1, 2, maybe 3 drops to do if the whole mouth is decayed. So it's very cost-effective. But what does it actually do? It actually arrests decay, which means it stops the decay process. So these brown teeth here on the left, this is decay. That's pretty obvious. And this is all soft, mushy decay. It's active decay. It's in the process of breaking down the tooth. And if you're not aware, caries is a disease. It is actually the most common disease in childhood. It's 5 times more common than asthma. It's actually caused by bacteria. It is sort of caused by sugar indirectly, because the bacteria eat the sugar, they produce acid, and they eat away at the teeth. So sugar and acid are not good for the teeth, but it's caused by bacteria. So there's a lot more bacteria living in these teeth. but after the SEF is applied, it arrests the decay. It eventually will harden the decay, the cavitated areas. It'll kill the bacteria. It's bactericidal, which means it'll kill the bacteria. But it stains the teeth. As you see, it stains the teeth black. So that's the biggest drawback. But it's so easy to apply that anyone can do it. And you can do it pretty much on any patient. You just have to hold them down. If it's worst case scenario, you'll hold them down and just rub with a tiny little brush. It's totally painless. It does taste a little funky afterward. Have done it to myself. It does taste like you put a mouth full of nickels or a bunch of nickels in your mouth. It tastes like metallic, but that doesn't last very long. But the staining does last a long time. If it does what it's supposed to do, it pretty much lasts indefinitely. Lasers are a big thing. I don't use lasers, but some dentists, especially pediatric dentists, that's all they do. They just love lasers, and lasers do a couple of different things. They can take out decay. They can replace a handpiece or a drill to remove decay. And I think it's about 75% of the time you don't need local anesthesia for that. So that's a good thing. That's something sort of to advertise in a practice builder. People like that. The other thing with lasers is soft tissue. So this here is a frenum. It's a little attachment, and you may have heard the term frenectomy, where you sever this frenum, this attachment. There's also one under your tongue or on your lip. You can probably feel them if you move your tongue around. So they typically do this on kids, especially with the tongue. If they're having difficulty talking or breastfeeding, they'll do that. And then also up here, they'll do that. If there's a really strong attachment here, it causes a bigger gap. So if they're going through ortho, then they'll do a little snip, and to help close that gap. So another thing that I really love is, this is the old way to isolate teeth. Because a lot of the things you have to do, they have to be dry, and it's a bit of irony that you have to do a lot of fillings that are dry in a mouth, which is underwater basically. So in dental school, you probably learn how to do the rubber dam, which, like, you see how many instruments you need just for this. But now we have, which I love, is this dry shield and ice to dry. It's a lot softer. It's not as scary as all this. It helps isolate, keep half the mouth dry, so I can do sealants very quickly on this half. Let's flip it over to the other side, or do as many teeth as I can, as long as the kit allows me to. And it also protects the airway. That's a huge thing that I always talk about. We're working with tiny little things like crowns, little things like this. There's tons of tiny little things that can go down the airway. And if the airway, if you get a little crown that goes down into the kid's airway, you can pretty much kiss your career goodbye. It's something, there's going to be a lawsuit or something. If the kid, worst case scenario, kid, doesn't recover, they die, then, that's awful. I mean, that doesn't really happen, but you always have to have safety first, protect yourself, protect the patient, protect your assistants, everybody. Okay. So, and this is a great way to do that. This is what it looks like close up. It's soft. And what this does, it not only keeps the mouth open, keeps everything dry, it sucks everything out. So it's hooked up to the suction. It's a really great thing. Okay, onto some cases. So this is a 9-year-old boy. He just came for a routine checkup, and he had this. You can see this tooth. You can appreciate this is not normal. This kid is tough. This kid didn't seem like it bothered him too much, but he wanted it out. He wanted to look normal. We've all gone through middle school, high school. Kids can be mean. You get bullied, you get teased, and you want to be like everybody else. And having a tooth like this, makes you different. It can definitely hurt your self-esteem. So we did take it out. You can just see how big it is. It's at least as big as the tooth next to it. This is the tooth that's supposed to be in the place. You can just see how it totally displaced it. So a supernumerate is an extra tooth. You can see here on the x-ray as well, it's a big old tooth. But eventually we took it out and put some braces on it, and then over time you can see how that gap got closer and closer. So that was a good case, and that was, you know, over a course of a long time, but very helpful to that boy. And this is a typical case that I would see in the OR. There is a lot of decay in the front teeth. You may have heard the term baby bottle syndrome. That sort of refers to the decay in the front teeth. We don't really use that term professionally. We call it early childhood caries or severe early childhood caries. And that's definitely the case here. But not only do you see that these teeth are decayed, but you can see some decay back here. But unfortunately, a lot of these teeth had to come out. You can see on the post-op on the right. Lots of crowns too. The goal is always to save the teeth, but if you can see, there's this little nubs here. There's nothing left to do. If these are permanent teeth, maybe you could do something, but on baby teeth, you have less. You can't really do certain things because you want these teeth to come out at a certain age. So you can't do what you may have heard as post-core crowns. That wouldn't work for these teeth. And then this buildup over here, this is fluoride. We usually put fluoride at the end, so it's not pretty. But we do it at the end of OR procedures. Here's a trauma case. With trauma, it's always the front teeth. It really, unless you're in an accident, like a car accident or something, you're not going to have any damage to the front teeth or to the back teeth. It's typically the front, and kids are always playing either in the playground, they run into a pole, they fall down the slide, fall off the swing, get hit with a ball. It's always something, always kids playing, or they're doing what their mom told them not to and jumping on the bed and hit their cousin. I feel like I hear the same stories all the time. But you know, this kid was autistic. We had to go to the OR. That's why you see him sort of draped in this blue. So he wouldn't sit still. So we brought him to the OR just to do this one tooth. But it came out pretty nice. It's not, you know, super aesthetic. You know, it's the color, you can tell, is a little bit off. And that's sort of the difficulty of doing something that we say is chair side or in the OR, because you have to do it right then and there. You can't, you know, shade match. There's only so many shades of composite, but if you go to, you know, do something through a lab, you have more options. But, you know, this helped protect the tooth, and it should last as long as he doesn't, you know, bite anything too hard or get into any more trouble. But I do typically do that. Here's another trauma case. This is a younger child. These are primary teeth, or the last one was their permanent teeth. So here you can see that the teeth aren't at the same level. So why is that going on? Well, I'll show you here. So here you can see a fracture in the root. So since that happened, the tooth came out a little bit, or extruded. And in this case, what you have to do is take the tooth out. Unfortunately, this little piece, it's not likely that it'll come out. So you have to leave that, but it's okay. Sometimes you have to leave a little bit of tooth there. Typically it'll come out on its own or get pushed out by the permanent tooth, which is here, over time. That's what we did. And you can also see decay here, sort of secondary. This is sort of a little mild case, but it definitely made a change. He is what we call a tongue thruster. So you can see the space between the upper and lower teeth. This is a pretty common thing. Kids will sort of push their tongue through their teeth and sort of make this little space. So it's a habit. And what I put in was this habit breaking appliance. So instead of pushing his tongue through his teeth, he pushes it along this little rake here. So it's like a little fence. See, over time, it closed. And the teeth close on their own. As long as there's not something in the way, they'll close on their own. So you got to work with the body to, do what it's supposed to do. So it's a little mild, but cute little thing. Here's something that's weird. I saw a couple of these cases recently. So this is a space maintainer. This is called a band and loop, and you typically put these in after you take out primary teeth, so that these teeth, this tooth doesn't start to angle in and grow in this way and block the permanent teeth that are supposed to come in here. So it's supposed to be 2 teeth here. This is a permanent tooth. These are baby. This is a baby tooth. These are permanent teeth. So what happened here is some dentists put this on after they took out the teeth, and then the gingiva grew over it. So one of the things they did wrong here is you're not supposed to put a space maintainer like this if there's 2 teeth missing. You only do it if there's 1 tooth missing. So that was the first mistake. That was the biggest mistake of it. So in order to get this out, I had to do a little minor surgery, which typically don't do. I typically don't pick up a scalpel, but I had to, just to cut a little bit, just a little bit, not too much, but I got it out. So sometimes when you do the same thing over and over again, it's nice to have little things like this that make it a little bit more challenging or just a little different. But I just had to numb the kid up a little bit and take this out. It wasn't too bad. Here's a pathology case that I had, and this is one of the most significant cases I've had in my career. This girl came in with a swelling on her left. You can't really appreciate it here, maybe a little bit, but it was definitely swollen over here. And typically, that's not too rare with kids. Typically, if there's big decay, like you see here, and you see down here, these teeth are just broken down in this black area down here. The decay went through here, the infection went through the tooth, broke down the tooth, caused that cavity, and then it would spread into the roots and into the bone here. So that's typical. And sometimes this will spread to the face as well. So when I see these broken down teeth and I see the decay here, the decay in the roots, I'm not really surprised that there's a facial swelling. However, when I looked over here on this left side, it's all dark over here. And there's supposed to be bone here. And bone is supposed to look like this. It's supposed to be this spongy look. So what we did, we took a panoramic x-ray. And hopefully you can see this. There's this giant area on the left here, this dark area. So it's supposed to look like this, okay? This tooth is the same as this tooth. And this tooth, this is your ear right here. This is your jaw. This is your condyle of your TMJ right here. So your tooth is not supposed to be way up here, right? It got pushed by this tumor, and this tooth is the same as this tooth. So this one here is supposed to be in the mouth, where this one is clearly not in the mouth, is being pushed down. And that's been done by this tumor. And this girl, I think, was 7 years old. So unfortunately, she had to get this removed. Well, she got it, later that week. But this is what a normal panoramic looks like for a 7-year-old. We call these 6-year molars because these come in around 6. These are permanent teeth. These are permanent teeth. These are what we call 12-year molars. These come are at 12 years old typically. So these are first permanent molars. These are second permanent molars. And then if you go back, you can see again how pushed this is toward the condyle of the mandible. So big tumor. It's pretty much half her jaw. If the oral surgeon said if it was any bigger, she wouldn't have a jaw left. She just had almost like an eggshell left of her jaw. And unfortunately, those do recur sometimes. This is called a odontogenic keratocyst, and it's one of the more common jaw tumors, I believe. However, it's still pretty rare. This is the only one I think I've seen. I definitely haven't seen one this big. And then a little close up to see. So there's pretty much no bone left. You don't see that spongy bone like you should. This patient is a cleft patient. So that's another thing that you'll learn about, whether in dental school, or if you're an oral surgeon, or a pediatric dentist, or an orthodontist. It's big. The cleft was repaired. So this is a cleft palate repair. You can see, so you can see this is the cleft in the lip. You can't really see the lip so much, but you can see there's some abnormalities. So this is the midline. This doesn't look like this, and also these teeth don't look normal. So this is typical. There's typically dental issues in cleft lip and cleft palate, and that's because there's bones here and here that fuse with the front bone during development, and when those don't fuse properly, that's when you get a cleft lip, cleft palate, and there's usually dental anomalies like this. So there's these teeth are fused. These are actually fused. That's not really to do with the cleft, but it's just another similarity. And then these are malformed teeth. We try to maintain the teeth as much as possible with these, but sometimes they're just too infected to save, so we had to take them out because you want to maintain them for the bone. I'll go through this. This is another one. Just decayed almost every tooth, and we had to take out almost every tooth. This kid, I think, was only 3 years old, very young. Very unfortunate. Again, another OR case. You kind of see abscesses here, which is common when you see decay like this. These are infections that go through the tooth into the root, through the tip of the root. Again, we have to take out these teeth, a lot of crowns. Another supernumerary. This one happened to be back in the palate of the tooth, or the palate of the mouth. And if they're out like this, where you can see them, or they've grown into the mouth, then they're easier to take out. If not, then I typically send that to the oral surgeon to take it out. Ooh, I kind of messed up with this arrow, but right here, there's a little white spot, and there was a little, I guess it's a supernumerary. It could be what you call an odontoma, which is basically means tooth tumor, a little tumor that looks like a tooth. If you look up odontoma, you'll see some stuff. Oh, and this is hypermineralization, which means the teeth are not as mineralized as possible as they should be. So you get this chalky sort of look, and this brown staining as well. And the etiology of this is sort of unknown. What is it? Genetic? Is it diet, environmental, things like that? So it's hard to say what exactly happened there. So I know we're getting toward the end here. I'll just jump through this stuff. Okay. So I do have a public health background. So public health is another thing you can do, especially with peds. A lot of pediatric dentists go into public health as well. But public health dentistry, a lot of it has to do with water fluoridation, and water fluoridation is one of the top 10 public health achievements of the 20th century. That goes along with, tobacco, learning tobacco and the effects it has, and workplace safety and vaccines and things like that. So it is a very significant thing. Field dentistry, which I've done, going into the field, going into schools, going abroad, doing outreaches. That's something I've done. This is a picture of me in Nepal in 2019. And you can go into research, that would include epidemiology, or other types of research, education, which I do a little bit of, prevention, policy development. So if you're more if you want to go into the political sort of setting, you can do that as well. This is a typical setup when we do our field dentistry. I go with NYU, the NYU outreach program. So we have these dental units here, which deliver we have the high speed, low speed hand pieces and suction as well. So we have dental students and dental residents that come along, and you can see all the supplies that we have. It's a great experience. Do that for about a week, and it is a big learning experience. This is Lou. I went to dental school with him. He's an oral surgeon now. And these are all the dental students, being taught how to take out teeth. And then, it's fun too. So if pediatric dentistry isn't enough, a lot of you do have the option. I won't say a lot of people do this, but you do have the option to go into ortho. There are dually trained pediatric dentists and orthodontists, or sometimes they do peds and dental anesthesia. More rare, they might go into endo too. Special needs dentistry, there are special needs dentistry fellowships. Those are typically a year. You can do those. Again, research, teaching, advocacy law, practice, brokership, consulting, just about anything. Okay, you can get creative with your job. So when it comes to applying to dental school, I'm not on any sort of admissions committee at any dental school. I mean, I do the admissions or the interviews at the GPR program I work at. But for me, I want to see someone that is sort of well-rounded, someone who's going to fit in, someone who's not just good academically, but someone who can communicate and is social and who's going to be amenable to learning and to take criticism, things like that. Because this is, you have to, you're going to make mistakes. That's normal. And you just have to learn from those mistakes. And you're willing to learn and to listen. But when you're applying to dental school, it's always good to be a leader as well. It's good to be part of a team. When you're a dentist, you are part of a team, but you're also the leader of that team. So you want to work well with others, but also, take initiative and be the boss, so to speak. So with me, there was a lot of balance. I think that really helped, especially when I was in college. Like my best semesters, I actually had 2 jobs, and I had the higher GPA, but I still had the most fun because I worked hard during the week and enjoyed my time on the weekend. So as long as I got all my work done, I had a good time as well. And I still use that through dental school. I still try to exercise, work out, try to have some fun, enjoy my friends, family, things like that. So you really have that balance, whether it's college, dental school, or during your career. So that'd be my recommendation. So that's it. Here's the quiz. I don't know if I should show that now, but that's, if there's any questions or anything, I'm happy to answer those now.
Sorry, we really don't have time for the Q&A session, so I think that's gonna be it.
Okay.
Yeah, once again, thank you so much for joining us, Dr. Trey Perez. We appreciate you taking the time to speak to us. And thank you everyone who joined us today on our live stream. The post-session quiz will be accessible through our website. So thank you, everyone.
All right, thanks.